So what has changed in imaging? We'll get to that. So first I want to go a little bit on advanced cardiovascular imaging. So it's really become an integral part of everything you're going to see today, and also cardiology in general, and even spreading beyond cardiology. And one thing I want to advocate for is we really have to get rid of this title of non-invasive cardiology, because that's really not what we do. So you'll see from, oh, well, I guess they skipped that slide. So, our division has 17 doctors at its fullest, and we do 100% imaging, and everyone has 1 to 2 extra years of training after cardiology fellowship. So we're really performing an advanced service, and some people have up to 6 board certifications for all the different imaging modalities. Most of my career, I spent 5 days a week in the cath lab, so I wouldn't consider that non-invasive at all. And if you ask any patient, I don't think they consider a TEE non-invasive, probably more invasive than an angiogram in a lot of cases. So that's my little spiel. So is this the, just want to make sure they have the right one. All right, we'll go with this one. I don't know if it's the most updated. So we have transcatheter aortic valve replacement, which we're going to focus on. So there's a couple things here. One is the balloon expandable, the Sapien, the Evolute, and then also what was mentioned before was the Navitor, which is a new valve from Abbott, which is also self-expanding. So really transthoracic echo is on the front lines of all of this. And this is a very clear case with a peak velocity of 5 meters per second. Let me just check. Do you guys have a second presentation? Because I think this is an old version. Yeah, because I had some other slides which I wanted to present. There was one I uploaded last night. Yeah, the one from last night.
This is the one from last night. Yeah, that's the only one we have.
Okay. All right. Okay, we'll keep going. So, a lot of the times these are clear-cut cases, right, with the regular parameters, peak velocity over 4, and mean gradient of 40, and valve area less than 1. But there are also many times where it's inconsistent. So there are discrepancies in the definitions, which we'll see in the next slide. And there are a lot of these other errors, and I'll go through some of them. So discrepant definitions of severe AS. So we know from some broad-based studies like this one, this is from Minners in 2008, that when we look at the echo parameters, what they found was that a valve area of 1 correlates with a mean gradient of 21 and a Vmax of 3.3. A mean gradient of 40 closely correlates with a valve area of 0.75. And a Vmax of 4 correlates with a valve area of 0.8. So there's some discrepancies inherent in the definitions, which makes it not completely black and white. Other assessments which can help us, looking at the valve. So if it looks really bad and the metrics aren't bad, then we may be missing something. Planimetry of the valve by either echo or CMR or CT. Indexing the valve, we have different calculations like projected valve area, which I'll go through, and also calcium scoring. So CT can be helpful with calcium scoring. As Khalique showed, there are pretty well-established cutoffs of around 1,300 Agatston units in women and 2,000 in men for severe AS. Once we establish the diagnosis, a lot of the work is done on the CT. So we have the aortic root assessment, which we do. And this is really based on this image, which is a schematic of the aortic root and what we call the virtual aortic annulus. So that's the green plane at the bottom. And that connects the 3 hinge points of the aortic valve in the left ventricular outflow tract. And most of the other measurements are based on this one. And this is how we really size our valves and determine risk for some of the complications. So in our checklist, we have different things. I mentioned the annulus dimensions. We have coronary distances, and we have calcification in the LVOT annulus and also the leaflets. We get also our dimension of our sinuses and the surrounding areas, and I'll go through why those are important. So the manual way we would measure this is we hone in on each of the 3 hinge points on the CT, and this is something called the double oblique technique. We also have many semi-automated programs which will find these 3 hinge points for us, and we can create that plan. So this is one of the examples of a semi-automated platform called 3Mencio. This is an example of an annular measurement we would do. So you saw some of these in the cases. So an area of 400 and a perimeter of 72 in our ellipticity measurements, max and min diameters. And we take these to sizing charts, which are pre-formulated, and we choose our valve size. We have to be very precise with these measurements. So these are some cases where we could be either too high or too low, and that greatly alters the sizing. So we have to really hone in on that plane. So this is how we measure our sinuses. In this case, you see sinuses around 29 to 30, and these play into some of the risk profiles that we're going to calculate on the next slides. So this is an example of how we can do something similar on 3D TE, and we published on this years ago, validating it against CT, but it's essentially the same protocol. So we're really going to hone in on that plane and do all of our measurements and take those to the sizing charts. We can do this on cardiac MRI as well. There's a little bit more of an advanced technique. Yeah, can we swap them? All right, and the same concepts here will apply regardless of the modality. So the left-hand picture is a 3D echo, the middle one is a CT, and then the next one is an MRI. So it's really all similar, and we just do what's best for the patient in the certain scenario. This is an example of a recent no contrast case actually done by Will Chung, and he's the one who advocated for this patient to get no iodine contrast and just to get an MRI instead. So we did actually a non-contrast MRI and got these images, which were very diagnostic for valve sizing. Then what Will proceeded to do was use pigtails without any contrast to really mark the bottoms of the cusps, and had this nice valve deployment of an evolute with a good result. So one thing we're developing is called photon counting CT, and I'm going to go on to explain what that is. So about 2 months ago, we became the first and only hospital in the nation to get this cutting edge technology, which has really been described as the holy grail for CT for the past 10 years. And this is the first scanner where they've actually developed that technology. So we got it about 2 months ago. This is the team, myself, and the managers and technologists in CT. So what is photon counting? We're going to get a little bit nerdy here. But usually the way we do CTs is the tubes shoot out a bunch of X-rays of different energies. The detectors collect those X-rays, and what you basically get is an average. And the way it's done is the way it sounds. It's very messy. So these are called energy integrated detectors. So that's 99% of CT scanners that are out there. And then multiple steps are used to convert that into a signal, which is the image we can interpret. And we call it a blended image. What the photon counting detectors do is very different. So they actually accept all of the energy profiles and can count each and every one. And they convert the energy directly into images. So this is a one-step process. So that also, other than making it faster, also improves our image quality. So benefits: improved image contrast, lower image noise with better spatial resolution, lower radiation doses, and multi-energy information. And I'm going to show you what that means practically. So this is a recent example. So this is a patient who came for a low contrast CT scan because they had chronic kidney disease. So the left-hand image is, what the scanner spits out. But what's different about this, I mentioned the different energy profiles. So iodine is better seen at certain energy profiles, and the iodine is the contrast, the bright part of the study. So what we did is we reconstructed this using only a single energy level that was different, and that made the image brighter. Now, what's different about this than normal CT, what we call windowing, where you can make the image brighter or darker, is that you notice only the iodine contrast is brighter, the rest of the image isn't. So we're fundamentally changing how bright this image looks using the physics that are inherent in this technology. And this was done with 30 mLs of contrast. So most CTs are done with 70 to 100 mLs of IV contrast. And let's see if this is going to play. Can somebody just click on the middle of this video, like just somewhere towards the middle? Are you able to do that? On the play button. Okay, so that's okay. So, okay, here it goes. So this one's a little glitchy. So, but what I just want to show here is this is the same patient, and with just that 30 mLs, so just to think about it, a regular Coke can is like 200 mLs, so it's very little. And we're getting bright images on both sides of the heart with the contrast diffused through that whole space. And we can do that because of this technology that we're using. So these are beautiful images, and nobody would ever guess this is a 30 ml image. They would say 100 mLs if you ask somebody blindly. So why are these measurements that we're doing so important? Well, we have numerous studies, which Jaffer touched on a bit, but I'm going to describe further, with outcomes based on imaging. So we know that for sizing, so that was the annulus size we mentioned, that we need a certain sizing profile of our valve that's equal to or above our native size so that it can anchor in with force. And what we've shown, and others, is that sizing predicts paravalvular leak. Those are leaks you can get around the device. And those leaks are clearly associated with mortality. So we try to eliminate leaks as much as possible. We can't have moderate. The most we can have is a mild leak. In terms of root injuries, which we discussed in terms of the bicuspid cases, we know from this seminal large study that moderate or severe calcifications in the valve combined with too much oversizing of the valve, so too much force being put in, creates an increased risk for root rupture. But back when these studies were done more than 10 years ago, people really didn't measure all of this stuff, so we had to find out through, unfortunately, complications, but also research. So now we do all of these measurements, and that plays into what we do, as you saw the discussions between getting surgery, doing transcatheter valves, which ones to do, how to do the case, et cetera. The other complication which Jaffer touched upon with the basilica, the cutting of the coronary leaflet, is coronary obstruction. So basically what happens is when you put in your transcatheter valve, if the root is small or the leaflets are bulky, your native leaflet can go into your coronary ostium and obstruct it, and that's a catastrophic complication. But the good news is we do very careful measurements on these. So this seminal study, which showed that when you have a root diameter less than 30 and a coronary height less than 12 from the annulus, that gives you a much higher risk of coronary occlusion. And this study is about 10 years old now, and that's the best we had until this year, where Jaffer and a large multi-center group published this large trial honing in on better characteristics. So essentially, a combination of the coronary leaflet length, the distance from the modeled valve into the coronary artery, the level of aortic valve leaflet calcification, All of those combined create a much better risk model, which we use now to predict some of these complications. And if we think the patient's at high risk of coronary obstruction, that's some place where we would discuss either doing surgery or perhaps doing a basilica, so cutting the leaflet with electrosurgery. So, we're in the golden era of TAVR. What's next? So we have all of these amazing trials showing the equality or in some cases even superiority of TAVR over surgery. So what really are the problems that we have next? Are there any problems remaining? Well, there are many conundrums which are going to occur now because we're implanting these valves into younger patients. So in the first partner trials, when we started 10 years ago and things were first approved, this was only a high-risk group where we were doing TAVRs, so 80 years old and 85 years old, who weren't going to live more than the next 5 to 10 years, no matter what. But now we're in younger patients, so you saw examples of patients in their 60s. So these valves are going to be in for a long time. So one of the things that was discovered is leaflet thrombosis in TAVR. But it's also present in surgical valves, so we'll go through that. So what is leaflet thrombosis? So what happens is you get layered thrombus on the bioprosthetic leaflets of the valve. And this was originally discovered on CT scans several years ago and published in seminal papers in Lancet. So you see this kind of dark area, which you see outlined in by the arrows. So what's the concern with this? Can we just anticoagulate and get rid of it? Well, we're concerned because this could be an early nidus for valve degeneration, which I'll discuss further. And we're also concerned because these are very hard to detect. Right? So these are some criteria conglomerated from multiple studies, which show how you would detect these using echo, right, which is the first line test. Patients come in, they get their repeat echo, and you see, is their valve doing fine? So in patients with reduced leaflet motion by CT, so the leaflet's motion is already reduced by the valve thrombosis, what was found is an absolute change in mean gradients from the baseline TAVR of 4 millimeters of mercury. Okay, that's an extremely small amount, and most people would just write that off to variation of the study. And these other metrics are very similar. So something that you would actually notice only comes in when you actually have stenosis. So that means a significantly reduced valve area, not just reduced motion. And that would be a mean increase gradient of 10, which would be noticeable. But that might be too late in some cases. So that's the issue. We need to really detect these early. And how do we do that, and what do we do about that? So very difficult to detect these, extremely difficult, I think, because at this early stage, patients aren't symptomatic, they feel fine. So some of the things that are being developed now, we recently had a journal club on this. So these are some predictors when you look at the post-TAVR CTs on who will develop this leaflet thrombosis. That could be eccentricity, volume of the new sinuses that form around the valve, and also how asymmetrical are the valve leaflets. Now this is great because we have ways to know if leaflet thrombosis may occur, but the question we don't know is what can we do about it that's really going to improve things for the patient. So this is a study done on explanted TAVRs where they went through histopathology and actually saw what was the progression of the pathology. And it was a very clear progression. So first thrombus, that thing I showed on CT. Then you get fibrosis on top of that after time, so after 60 days. Then you get calcification on top of that. So it's this very clear progression. So it's pretty clear that the nidus for all of this is that first step, the thrombus, which occurs very early, where patients are asymptomatic. Now, this is a surgical study people cite on explanted surgical valves where they said only 11% of the explanted valves, so not 11% of all valves, but only the ones explanted, which were a small proportion of everybody who got surgical valves, had thrombus, but on gross pathology, so only if you could see it visibly with your eye. And that's not really what we see in these. So this was a case of what did cardiac imaging show? So like the physical exam, WNL, we never looked. Right? This has never been looked at on surgical valves, really. So the same group who did the previous analysis did an explant study of surgical valves and found exactly the same pattern. So you get thrombus, you get fibrosis, and you get calcification. So there's no real difference between the two. It's exactly the same pathology and profile. So commissural alignment, we're going to move on to next, and coronary protection, which go hand in hand. So why do we need commissural alignment? So most of the times when we put in a TAVR now, the commissures of our TAVR where the leaflets connect are offset from our native commissures, right? So it's not exactly anatomical. Whereas in surgery, when they cut the valve out and put something in, it is anatomical. It's aligned with the native anatomy. So what could be the advantages here? Coronary access. We would think mimicking the native anatomy, which has lasted us longer, would be better for hemodynamics. And then the questions about durability. So this is an engineering study, and there have been a few which show more leaflet stress on your TAVR leaflets if they're not aligned. So how can we get commissural alignment? So there have been studies done on the existing valves, SAPIEN, Evolut 3, another one is Accurate Neo, which is still investigational in the US. And what they basically showed that for SAPIEN, you couldn't predict how to align it with various methods, and the other two you could predict to some degree, but not perfectly. There are other valves being developed now, which will come out currently in clinical trials, which have innate mechanisms to align. So you see on these, there are these external locators which will sit outside the valve in the aortic root. So basically will capture the leaflets and will align the valve with the native anatomy. This is an example of a Jena valve, which is mostly being used for AR, but the trial is now completed, where you see the three locators with the red dots in the root. The center part is the valve frame, which will then expand, but this allows perfect alignment with the native anatomy. And this is what it would look like on the TEE. And we did a small study on this at Columbia with some of the patients, and we found that 85% of patients had perfect commissural alignment, and 15% had mild misalignment, so less than 30 degrees off. So overall, much better than what we currently do with the commercial TAVR devices. The commissural tab, the orientation of our commissures also affects our coronary access. So the way it affects it is that your coronaries are in the middle of your sinus. So if your commissural tab is at your native commissure, it doesn't go in front of the coronary. But when it goes into the middle of the sinus randomly, which is what we do now, then it does block your coronary artery. Not immediately, so you're not going to have a complication, but later on in these younger patients, when you need to do an invasive angiography of their coronary, you may not be able to access it because you'll have something sticking out in front of you. Pacemaker prevention, so this was mentioned. So we know that there's a mortality signal with pacemaker insertion. Dave can tell us why he thinks that is, but so we have studies on that which are pretty strong, I think. And the other thing we know is that the conduction system comes in between the right and non-coronary cusps through the muscle and not through the membranous septum, which is a non-muscular area which can occur under the aortic valve. So how can we prevent this? So there have been studies. This is one called MIDAS, and this is going to be a very busy slide, but I'm going to summarize it. So basically what they found was when you measure, I'll go one slide ahead. So you have this membranous septum, right, which is with the red bracket. So the patient on the left really doesn't have a membranous septum. That means the yellow, their conduction system, is sitting right under the valve. So when we put in a TAVR, and normally the TAVRs are a little bit under the valve annulus, it can impinge upon this conduction system. Whereas on the right, it will only go onto the membranous septum, which doesn't have the conduction system. So what they found in this study is that when you implanted at the membranous septum or above it, you had a much reduced rate of pacemakers, even in patients with pre-existing conduction disease. And as we know, aortic surgery as well, so open heart, has a rate of pacemakers as well for the same reasons, because we're interacting with this area as well. And various people have developed overlap techniques to localize those zones, and I'll just skip this for the interest of time. Bicuspid valves we discussed a little bit earlier. The standard surgical classifications are type 0, 1, or 2. We have different classifications which have now been developed for TAVR. So whether it's 3 commissures, 2 commissures with a RAFI, which kind of connects the fused leaflets, or a true bicuspid, which only has two leaflets and 2 rather than 3 commissures. But really what's important is that these are not really 3 distinct classifications. There's a variation. So you can have type 0 to type 1 and everything in between, type 0.1, 0.2, 0.25. So there's a lot of variation and gradation between the types. And what we saw with the measurements is that the annular area we use still at the baseline, and there's always questions should we measure above that? The problem with the above measurement is that it's extremely not reproducible. So you can't have accuracy without reproducibility. If Will gets 400 and I get 600, that doesn't help us on the supraannular sizing, whereas at the annulus, we're going to get the same measurement. And we know that valves are being developed and techniques to improve these, which the bicuspids have had historically higher rates of complications, but not for us because we did those cases perfectly. So we'll continue to develop all of that. I just want to touch a little bit on post-SAVR and TAVR interventions as we wrap up. So lifetime management was discussed. So if you take a 60-year-old and you're deciding which procedure to do, ideally they're going to live for 20 more years or so. So how many sternotomies can they get? Which one should they get first, SAVR or TAVR? Are they going to get a valve-in-valve or a reoperation? So these are all questions which come up. And a lot of this is going to be guided by imaging. So, all right, I'm getting a message. So we have to decide on these things. So what are the advantages and disadvantages? And a lot of this is based on imaging. So these are just some diagrams of the different combinations that you could have and where you would place your new valve. Would you operate first? And how would this affect the things we've already discussed? So that would be, what else can you do after that? And also coronary access is always a big one. I'll skip some of these slides, which I think will be discussed later. So these are just different analyses that people are doing. So the last thing I just want to say is that computer modeling. So I think this is where things kind of have to go in the future because these are such complex scenarios. It's very hard to predict everything. So these are examples of companies that are out there. This is FEOPS and a bicuspid valve. So you see how they've predicted with computer simulation. How is this valve going to be deformed? What are the problem zones? And you'll see in a second these lines which indicate paravalvular leak. That's going to come in a second, I think, paravalvular leak. So those lines indicate where there's going to be a paravalvular leak. And I've done some work with them on validation studies with real TAVRs, and the predictive accuracy is pretty good. This is another example of the same thing from another company called DASI Simulations, just showing the movement of calcium, modeling a 26 and a 29 valve. So much more sophisticated than what we had shown before with just a circle in the aortic root. So this is really showing us what we predict is going to happen. That's it from me. The live case is ready.